So today I'm going to be speaking to you all about basic cardiac ultrasound. After your rotation, I'm sure you all know tons about this. So I'm going to pick on people and make you join in and participate. So it'll be more fun, okay? Bex says, I don't know how much I could participate. Corbin is a rock star, but this stuff, you all know this stuff, okay? So our objectives, so we'll talk about cardiac views, fluid status, ejection fraction, and then just some brief pathology. And so in regards to the cardiac views, before I get started, I do want to give a shout out to Dr. Din. I adopted some of his slides that he previously made a great lecture on. So some of them are thanks to him. So in regards to cardiac views, there's four main views that we know to look for: our parasternal long, short, subxiphoid, and apical 4. And we'll talk about them a little bit more here. So we like to follow a systematic protocol. So if you follow a protocol every time, it helps you not to get confused and make sure you got all the views that you need every time. The way most of us learn is to start with the parasternal long, then rotate 90 degrees to the short, go to the apical 4, and then finally the subxiphoid. So in regards to the parasternal long, when we're using cardiac mode on our ultrasound, we have the indicator to the right shoulder next to the sternum. We start around the 4th intercostal space and we'll slide up and down the sternum to get our views that we need. It's always important to make sure you have the left ventricle on the left side of the screen. That's how you know you're, in the right mode, doing the right thing. And we all know these already, so you should know where your right ventricle will be located, the left ventricle, your outflow tract, and your left atrium. And it's always important to include the descending aorta in your parasternal long view. Quickly onto the parasternal short. We'll now have the indicator towards the left shoulder, and we're going to kind of slide through 3 views in the parasternal short. So in one of the views, we'll be able to take a good look at the papillary muscles. Then you can slide the probe towards the mitral valve in order to analyze that further. And then if you tilt the probe, you're able to see the aortic valve. And so this is a quick view of the mid-papillaries. And on ultrasound, this is what you should be able to see with your left ventricle and the papillaries in view, and then your right ventricle on the outside. Next, the mitral valve, which is the fish mouth view, which this is a great image showing that mitral valve right in the middle of the screen. And lastly, in the parasternal short, we can take a quick look at the aortic valve, which also known as the Mercedes-Benz, which you can see right there in the middle of the screen. Onto the apical 4. So to get this view, I'll go back a second. We're just sliding over. This one sometimes can be a little bit challenging depending on the patient's body habitus. So sometimes you may have to have the patient roll over onto their left side to get a good view, or sometimes we'll trace it down from the parasternal short to get to the base of the heart to try to get a really good view. And then, so for the apical 4, we expect to see the left ventricle on the right side of the screen, the right ventricle on the left, and then the right atrium and left atrium at the bottom of our screen. So Robert, you are eagerly awaiting a question. I feel it. So how big would we expect our right ventricle to be in relation to our left ventricle in this view?
In normal circumstance. Sorry, there's quite a bit of echo. In normal circumstance, we'd expect it to be about definitely smaller than the left ventricle, about half the size.
Yeah, so maybe around 2/3-ish, but definitely smaller than the left ventricle, right? So in this view, you can get lots of information. So if you see the RV is really big, then possibly they may have some pulmonary pathology or some reason for an enlarged RV. They may have a massive PE that's dilating the RV, but you can get lots of information. So great job. No one's safe in this lecture, even Dr. Jaffrey. Okay. So next, subxiphoid. So for this, we're going to go, well, subxiphoid. And then we're going to use the liver as our window in order to get a great view of the RV closest to the liver. And then the LV will be, just below that. This is the image that we use for our FAST exams to see if there's any fluid around the heart. And so you've probably done this on your scanning shifts. And so this is just a quick picture of that and what we would expect to see. Does anyone see anything grossly abnormal in this image? I'll play it one more time. All at once. No, we don't, right? That's pretty unremarkable. We don't see a big pericardial effusion. So this is just a normal heart. Fluid status. So when you're doing a comprehensive look at the heart, it is important to take a quick peek at the IVC too. And so when we look at the IVC, it's important to look at it during expiration and during inspiration in order to be able to assess their fluid status, if they have any dilation, if they have respiratory variation that we would expect. And so we'll go on to talk about a little measure that we can use to assess our central venous pressure. But first we look at the IVC during expiration and we can measure that. We then go on to measure it during inspiration. So you just have the patient take a deep breath when they can cooperate and measure that as well. And then we can calculate something called the Cavel index. Has anyone heard of that before? Natalie's nodding. Okay, perfect. So for the Cavel index, it's a quick calculation. We look at the expiratory volume minus the inspiratory and then divide it by the expiratory, and we get a number. And we expect the variation to be greater than 50%. Once we have that number, we can get a rough idea of what the central venous pressure will be. And so
this table is actually very high yield for the test. They want us ultrasound boards and for like critical care echo boards.
If you're not taking echo boards, it's still important because even if you don't remember every number in here, you can, even if you just remember greater than 50% or less than 50%, that can help out a ton. So if you see greater than 50% variation, your central venous pressure is somewhere between 0 to 10. So even if you don't memorize all of this, know if you see in variation, your central venous pressure probably isn't through the roof. And then if you're not seeing that amount of variation, your central venous pressure is probably higher. And so it's just something to be mindful of. And you can apply this when you're thinking about different pathologies for a patient. So if a patient has fluid around the heart, how would you expect, kind of a hard question, but what would you expect their central venous pressure maybe to be higher or lower based on fluid return? All right, Chris, you're up.
I would expect the CVP to be increased due to greater resistance. So.
And then what if they had a pulmonary embolus?
And if they had a significantly large pulmonary embolus, I also expect it to be increased.
Perfect. So you can kind of use this going into, when you're trying to make your differential diagnosis and try to figure out what the patient has. They don't come in saying, hey, I have a PE, right? So we have to try to put all these little pieces of the puzzle together to figure it out. And so this is one tool you have that can help you with that. Great job. So ejection fraction. So for E-point septal separation, has anyone done this on their shifts? You're all nodding yes, because I know Dr. Din taught this to you. Perfect. So for EPSS, we want to use M mode. And when we apply M mode, we can see our RV, the intraventricular septum, the mitral valve, the anterior and posterior leaflets, and the left ventricle. Does anyone know which one we look at to do it in the EPSS?
The anterior mitral valve?
Yes, perfect. So the anterior leaflet of the mitral valve. So that's one we're going to focus on. So we look, well, we can see these different views in diastole and systole, and we can see our E wave and our A wave. Which one are we looking at to measure?
The E wave.
Yes. Guys, you're so ready. You know all this. I'm so pumped right now. Okay, E wave, perfect. So here we're focusing in on the E wave, and with a normal ejection fraction, where are you expecting the anterior leaflet of the mitral valve to touch? Chris,
We expect it to hit them to touch the mitral wall. Or the mitral wall, sorry, the septal wall.
Yes, the interventricular septum, perfect. So that's what we're measuring. So on the left side, you can see how the anterior leaflet of the mitral valve is going, basically touching the interventricular septum, and on the right side, it's not. So we're concerned for decreased EF. So in regards to the measurements, an EPSS less than 8 millimeters is most likely normal. And anything greater than that, you have a decreased EF, and it based on how minimal the movement is of the anterior leaflet of the mitral valve determines how decreased your EF is. So there is a formula, it's not perfect, but you can use it at 75 minus the EPSS times 2.5, and then the EPSS is measured in millimeters for this formula. And so for this example, we're doing the measurement, and we can see here at the top, it's 0.626 centimeters, otherwise, or 6 millimeters. So if we do 6 times 2.5, that's 15. So 75 minus 15 is 60. So is 60 a good EF, or relatively normal EF, or really low EF?
Normal.
Normal, yeah, perfect. So this is a pretty good ejection fraction. There are some limitations, including mitral stenosis, if they've had any surgery on the mitral valve, if they have aortic regurg. EPSS is not perfect by any means, but it's one of the basics that you should be able to look at, the anterior leaflet of the mitral valve when you're doing an echo, and have some kind of an idea of what their ejection fraction is. So now the last section is just on pathology. So some of our must-know diagnoses are cardiac standstill, pericardial effusions and tamponade, RV strain, and then, like we just mentioned, the ejection fraction. So who haven't I picked on? Karen, I haven't picked on you yet. What do you see here in this image? Oh, I went past one. Go back. Sorry. What do you think about that heart?
There's not a lot of contractility.
Definitely. So here we see cardiac standstill, right? Our heart's not doing a whole lot of anything. So that's something that you should be able to pick up when you're doing your echo. Who's next? Okay, Robert, what do you think about this one?
Pretty similar. There's no good contraction, and it's just maybe some specific area firing, but no organized movement.
Perfect. Yeah. And what about this one? Play it again. What do you think, Chris?
Very similar, yeah. No good organized movement for adequate contraction. I'd say probably it looks like it's fibrillating, possibly.
Yeah, and like you said, there's your cardiac output here would be very minimal, right? Okay, we'll just keep rotating. So do we have any other residents or anyone else that I'm failing to pick on? All right, Karen, what do you think?
It looks like that there's fluid below the descending aorta, so probably a pleural effusion, but there's also a little bit of fluid above the descending aorta, so a pericardial effusion as well.
Awesome, yes, perfect. So that's exactly what you said. So that's why it's so important to get the descending aorta in view, right? If we see fluid right above and crossing over the descending aorta, then we're definitely concerned for pericardial effusion. But if we see it on either side of the descending aorta, then it's more likely related to a pleural effusion. Robbie, what do you think about this one?
Looks like so I definitely see fluid crossing over. And it looks almost like the swinging heart picture for some excessive pericardial effusion.
Yeah, just like your presentation, right? Tons of fluid around the heart. And then this one's a little bit more tricky. What do you think, Chris?
Well, I'm seeing fluid certainly around the heart. It looks like we're getting some diastolic, oh gosh, what's the word I'm looking for? That inward motion of the cardiac wall due to increased pressure outside, so likely a cardiac tamponade. It looks like I'm seeing. But,
and do you see fluid anywhere else besides just around the heart?
Oh, let's see. So let's see. I definitely see it around the heart. I'm seeing. Oh, is there also some around it, around near the descending aorta there that I'm seeing, or no?
I don't see there.
I don't really see that. So,
what do you think about that?
Oh, now, initially I assumed that was venous, but is there fluid below the diaphragm then down there? Is that what I'm seeing?
Definitely some fluid. So this fluid is actually in the abdomen. And so we can see fluid both in the abdomen and around the heart too. So that could be a little bit tricky. But if you follow the heart and you follow the pericardium, you could see the fluid limited within the pericardium around the heart. And then also at the top, we could see it in the abdomen. So you could see fluid in so many places. Sometimes it could be hard, but this one has it in the abdomen. You can kind of see it by the liver. Do you see it?
That's interesting. Yeah, I had thought that just because of it's sort of linear in nature, and I thought it was compressing, so it looked like a vein to me. But now I can see, especially it enlarges in a weird way as it goes around that hepatic, I guess what's called a corner there. It looks like, but it changes. So I see. Yeah, it just goes to show I got to look a little harder.
That's why we always get lots of views in ultrasound, right? Because they love to trick us. Okay, perfect. So next, who's up? Are we back to you, Karen?
Yes.
And then maybe for time, we'll go through a few more and then I'll probably just whiz through a few so that I don't hold you all up.
I think I'm just saying right atrial systolic collapse.
And what do you think about the right ventricle?
Oh, it's compressed.
Yeah. So what might this patient have? There's a special diagnosis.
Is it not tamponade?
Yeah, that's it. Perfect. Yeah, so that's what we're concerned about with this one. So Robbie might be able to stick a needle in this one. Awesome. Okay. Next. And so here again, we can see, bouncing and a large pericardial effusion. So this is something else that we're looking for. And again, another large pericardial effusion. This is huge. It's just a bit of a lower quality image, that one. So this one, I want you to look at the chambers of the heart and see if any, if they look the right size, if they look big, if they look odd, what do you see on this one?
It definitely looks a little bit odd. It looks like the walls are thickened.
Okay, what looks odd? Which ventricle or atrium or?
For the septal wall and the right or left ventricle wall, it looks a lot thicker than normal.
What do you think about the right ventricular outflow tract? So focus is right here. So in this one, once you look a lot to them, you'll see this one looks a bit bigger than normal. So our right ventricular outflow tract here looks pretty big. And so that can clue you in that there's some kind of strain on that right ventricle that's making it larger than it should be. And so we'll go for it. So here, this is a normal heart. And if you see that right ventricular outflow tract, it looks smaller in relation to, let me go back again. In regards to this one, that's that looks pretty much as big as the whole left ventricle if you think about it, like comparing the two. And so that's pretty dilated. So again, we could get more views to try to confirm what we're thinking, but right there, it just looks a little bit larger than usual, or quite a bit larger than usual. And then you may have heard of something called the McConnell sign. Has anyone heard of that before? Okay, Karen, what is it?
I think it's where the apex is
without reading.
contracting more than the rest of the right ventricle.
Yeah, when do we see this?
I think it's not specific, but we can see it for PE.
Exactly, yeah. So this can clue you in. So just another little hint that, a diagnosis may be something, or one of your differentials could be a PE for that patient. And then has anyone heard of the D sign before? Yeah? Okay. Chris is thinking hard. That's you have a serious face there. But Robbie, what is it?
Instead of a nice concentric circle, there's some flattening near the right ventricle side, causing that due to increased size of pressure, just kind of pressing down to make it more into the shape of a D.
Exactly, yeah. What are we compressing, the right ventricle or the left ventricle?
The right ventricle is compressing the left.
Exactly. Yeah, so because of the increased pressure, we can kind of see flattening of that septum, exactly what you said. And so that's another clue that maybe there's some pathology going on causing that. I don't remember what I was trying to show you on this image. Okay. What do we think about the squeeze on this patient, Chris?
So we're not seeing very good squeeze. We're not that, we're not seeing very good squeeze. Doesn't look like the anterior mitral valve is getting even close to the septal wall. So it certainly has low cardiac output, or at least, yes.
Perfect. I think those are all the pathology pictures I have. You guys got all the life-threatening diagnosis, which means you all aced your ultrasound rotation, basically, right? Does anyone have any questions? No? Okay. Thanks, guys.